Many of the most difficult healthcare choices, and thus the bulk of ethical dilemmas related to healthcare, take place at either the beginning or the end of life. Thus, this lecture can be considered the companion bookend to the lecture on bioethics and the beginning of life. The ethical issues related to death and dying are relatively new and would not have been raised a few generations ago when most life-sustaining technologies and medical interventions had not yet been developed, and the focus of healthcare was on curing or controlling disease, or at least promoting survival. The more successful that advanced technologies and techniques become in sustaining life, the more challenging decision-making becomes. As death nears, we have managed to greatly expand both our treatment options and our ethical dilemmas. Historically, the response to illness and injury was to try all available measures and hope that something would be effective. Questions such as, are we treating too much? Or, if we cannot change the downward trajectory of this patient's condition, what do we hope to accomplish by not permitting his body to die? And, are we prolonging his life or suffering? Would not have been asked. But these are the questions we must now not only ask, but answer. Decisions about end-of-life care require great scrutiny of the likely outcomes of therapy, including the important distinction between physiological effectiveness, or will the treatment work, and therapeutic benefit. Will the patient be better off because of treatment? We must recognize and take into account that cure-oriented and life-sustaining measures are not always medically appropriate for or even wanted by patients. Bioethics can be applied to help facilitate decisions about when to deliver the patient from death and when to let death deliver the patient from us. In order to proceed with any discussion of the ethical issues surrounding death, two questions must first be addressed. One, what is death? And two, when does death come? Currently, there are four main conceptual approaches to defining and determining death: heart-lung, whole brain, higher brain, and brainstem. All four of these formulations assume that life requires the integrated functioning of an organism. When that integrated functioning is lost, so is life. But exactly when this occurs is highly debatable. It is generally agreed upon that there is something fundamentally different between dying and being dead. But in fact, how do we know when death has occurred? The point at which the integrated functioning of the organism is lost can be challenging to identify. Consider briefly patients in a persistent vegetative state or minimally conscious state. Patients in a persistent vegetative state are suffering from a severely chronically injured brain. These patients are unconscious and do not respond in any meaningful way to the environment. When these patients twitch or move, the actions are merely bodily reflexes and have no purposeful meaning. Short of a miracle, clinical recovery is impossible. In contrast, patients in a minimally conscious state appear unconscious or unresponsive the majority of the time. There are inconsistent and erratic times when the patient has minimal but meaningful responses to the environment, such as being able to squeeze a hand or blink their eyes to answer yes/no questions. These patients may turn their head a certain direction in response to sound. They are bedbound, needing full nursing care, and are unable to retain information in their stored memory. For both patients in a persistent vegetative state and patients in a minimally conscious state, the integrative functioning of the organism is dependent on resources beyond the self. Yet most physicians and commentators alike would not consider patients in a minimally conscious state or even patients in a persistent vegetative state to be dead. So then, what is death? When does it come? What do these four definitions say about death? Historically, the time-honored understanding of death has been defined as heart-lung death, which is the total stoppage of the circulation of blood and a cessation of the vital functions of respiration and pulsation. The heart-lung definition of death is also commonly referred to as cardiopulmonary death, cardiorespiratory death, or clinical death. This is a definition of death that you still see used in the hospitals today on a regular basis. Confirmation of death under the heart-lung definition of death involves verifying that circulation and respiration has permanently ceased. Death can be determined through very simple procedures such as listening for a heartbeat with a stethoscope or manually palpating a patient's pulse. This definition of death was widely accepted until two major medical developments in the 1960s brought forth ethical challenges to defining death based on cessation of circulation and respiration. First, ventilators and electronic pacemakers made it a possibility to sustain both respiration and circulation indefinitely. Based on the heart-lung definition of death, individuals who had lost all brain functioning were technically still alive because they had respirations and circulation, albeit artificially maintained. Yet, to many, specifically family members as well as those caring for the individuals, these people were effectively dead bodies being maintained by machines. The second development involved advances in transplant surgeries. For successful organ transplant, organs such as hearts should be harvested from newly dead bodies. Patients whose respirations and circulation were being artificially maintained offered the opportunity to provide blood-circulating organs right up until the time of harvest. Donors who were being artificially maintained were usually medicated prior to harvesting to ensure they did not suffer when artificial life support was removed. They were also given blood thinners to help preserve the organs for transplant. However, some argue that these measures are hastening death. Others question if the removal of life support for the purpose of retrieving organs is actually murder. These challenges led physicians to press for a reconsideration of the traditional heart-lung formulation of death. The whole brain definition of death was proposed by the Harvard Medical School Committee in 1968 to deal with the challenges that biotechnology had created from the heart-lung definition of death. This new definition of death was based on brain function and would thus make some patients with devastating neurological injuries suitable for organ transplantation. Whole brain death, which has been more popularly referred to as brain death, requires permanent loss of all functions of the whole brain to declare a person dead. It is key to note that patients in a persistent vegetative state would not be deemed dead under this definition of death, as only their higher brain has ceased functioning, not their whole brain. To be determined brain dead, a person must exhibit the three following criteria. 1. Be unreceptive and unresponsive to applied stimuli. 2, lack movement and breathing for at least 1 hour while being continuously observed by physicians. And 3, lack of reflex actions such as blinking or eye movement. To confirm death, an electroencephalogram, EEG, can be performed. A flat EEG would confirm a permanently non-functioning brain. This alternative to the heart-lung definition of death was accepted in 1981 under the Uniform Determination of Death Act and thus provided a second legal standard of death in the United States. In response to this new definition of death, some critics have argued that the concept of brain death is irrelevant because the activity of the brain, since the brain itself is an organ, depends on perfusion, or circulation and respiration. Others began to question if all function of the brain needed to be lost for death to be determined. These commentators questioned if the whole brain was necessary for death, or if loss or functioning of just part of the brain was enough necessary to declare a person dead. The addition of the whole brain definition of death certainly expanded the conceptualization of the definition of death and the number of qualifying patients in the United States. Yet, the whole brain death definition didn't go far enough to suit scientists and philosophers who didn't see why all functions of the entire brain had to be permanently lost before a declaration of death could be made. These critics argued that the higher functions, such as consciousness, thought, and feelings, were commonly accepted hallmarks of personhood, and functions of the brainstem, such as reflexes, had no role in sponsoring consciousness. Thus, these critics have proposed a higher brain criterion where the irreversible loss of functioning in the cerebral cortex would be the primary physiological standard for defining death. It is key here to note that this definition of death is a proposed formulation and is not currently recognized in the United States as a legal method to declare death. If the higher brain formulation would be accepted as a definition of death, death would be equated with death of the cerebral cortex because the cerebral cortex is what controls consciousness and what many deem controls the essence of personhood. This definition of death raises an important challenge in that under the higher brain formulation, many people in a persistent vegetative state would be considered dead, as well as would people in a coma, even if they could still breathe spontaneously, even if their heart was beating spontaneously, and even if scans showed they had sleep and wake cycles. Thus, under the higher brain formulation, people who were still displaying functions that were once deemed vital and necessary for life, such as spontaneous breathing and spontaneous circulation of blood, would fit the criteria for death. The brainstem formulation is another alternative that was proposed in response to whole brain death. Again, like the higher brain formulation, the brainstem formulation is a proposed definition of death and is not legally recognized in the United States as a means for determining death. The brainstem formulation accepts the validity of declaring death based on neurological grounds, but contends that a permanently non-functioning brainstem is always adequate for determining death. Determining the functioning of the brainstem can be accomplished by simple bedside tasks such as assessing for pupil response. Commentators in support of this view argue that consciousness, as well as heart and lung functioning, depend on a functioning brainstem. In other words, while the heart and lungs perfuse the brain, if the brainstem is not telling the heart and lungs to work, then perfusion will not occur. The challenge to the brainstem formulation, which is also a challenge for the whole brain and heart-lung definitions of death, is that death is viewed purely as a biological concept. However, in contrast, the higher brain formulation is limited in that it views death purely as psychosocial. Thus, in an attempt to answer the questions of what is death and when does it come, we must now consider if death is better understood as a biological concept or a psychosocial concept. So, biological definitions of death focus on the permanent loss of what is essential as an organism, what keeps an organism alive. And the heart-lung definition is a biological definition. This definition says respiration and circulation are essential for life and what keeps us alive. When they cease, we are dead. The whole brain death says that for a person to be alive, their entire brain is functioning. For a person to be dead, none of their brain can be functioning. And then for the brainstem death, this definition says that the brainstem is what causes respiration and circulation. So therefore, if the brainstem is dead, then your higher brain would also be dead and you wouldn't have respiration and circulation. So really, we just need to look at the brainstem, and that's what determines death. The psychosocial definition of death, however, considers what makes us essentially a person. And under this definition, what makes us a person is not our ability to breathe or circulate blood, but rather our ability for consciousness and or cognition. So proponents of the psychosocial definition of death say that while somebody may still be breathing and their blood may still be circulating, if they don't have consciousness, they don't have cognition, they've lost what makes them a person, and therefore they are dead. We're going to look into this in a little bit more detail. We are now going to take some time to look at the ethics of the biological and psychosocial perspectives of death. First, we will focus on the biological perspective of death. According to this perspective, loss of all brain function disrupts the integrated functioning of the heart, the lungs, and the brain. In other words, the heart, lungs, and brain work together, regardless of if your belief is that the functioning of the heart and the lungs is how death should be measured, because the heart and the lungs provide oxygen and blood circulation to the brain so that the brain can work properly, or whether you believe that brain function is how death should be defined because the brain sends the signals to the heart and the lungs to work. Either way, the heart, the lungs, and the brain are interdependent, and according to the biological perspective, it is not whether the heart and lungs rely on the brain or whether the brain relies on the heart and lungs. This perspective recognizes that the interworkings of these three organs is what keeps someone alive. Therefore, under the biological perspective, either the whole brain definition of death or the heart-lung definition of death would be acceptable. Therefore, this is why in the United States, you do see some hospitals who choose to define death based on whole brain death, and some hospitals that use the heart-lung definition to define death. Either definition is appropriate and acceptable under the biological perspective. Next, we're going to look specifically at considerations for patients in a persistent vegetative state under the biological perspective. And we focus on this patient population because it is the care and treatment of patients in a persistent vegetative state that are often the source of ethical dilemmas surrounding the definition of death. And an excellent example of this is the case of Terri Schiavo from the early 2000s. Many of you may recall this case. If you are not familiar with the case of Terri Schiavo, I do have a YouTube video under the recommended videos for this week. It's about 13 minutes, and I would encourage you to watch the video. As a reminder for those of you who are familiar with the Terri Schiavo case but really don't recall the details, Terri Schiavo was a lady in a persistent vegetative state. Her husband wanted to remove her feeding tubes that were keeping her alive, and her parents did not want this to be done. So when we are considering a patient in a persistent vegetative state, we have to consider how we define death and how we define removing the machines that are keeping a patient alive. So, under the biological perspective, patients in a persistent vegetative state would be considered alive because they are exhibiting the integrated function of the brain, the heart, and the lungs. Therefore, the use of the biological perspective to define death brings about some ethical questions. The first question is if there is a moral obligation to maintain the life of someone in a persistent vegetative state once the person has been deemed to have no chance of regaining consciousness and no chance of regaining any purposeful forms of responses. Another ethical question is regarding allowing this person to die by removing the machines that are keeping them alive, such as feeding tubes. In the case of Terri Schiavo, her heart was beating spontaneously. Her lungs were breathing on their own. However, she was being fed through a feeding tube. So ultimately, the feeding tube was the machine keeping her alive. And if that machine was removed, she would starve to death. And the question here was, since her heart is beating, her lungs are pumping oxygen, and her brain is still showing activity, is removing her feeding tube mercy or is it murder? The third big ethical question posed through the biological perspective is, does the biological perspective allow room to recognize death as a process, or does it limit defining death as an event? And there are some people who hold to the fact that death is a process with stages that an individual goes through. And you might have heard these referred to before as the stages of dying. On the other end, there are those who say that death is a single isolated event that occurs. And how you determine death as a process or an event greatly impacts how you define the point of death. The other side of this debate is the psychosocial perspective. Proponents of the psychosocial perspective say that what makes us uniquely human, such as our consciousness and our cognition, our awareness of our environment and our thought, is what matters when determining death. And they say that whole brain death may capture the death of non-human animals, but it does not capture human death because it does not differentiate what makes us distinctly humans. Therefore, the fate of patients in a persistent vegetative state under the psychosocial perspective is that they are dead. That a patient that has no awareness is not able to think, is not able to reason, is not able to remember, and is not able to function as a person. They are dead. They have no personhood. And so the question then becomes, well, how are we defining personhood? And I know you all had to grapple with that question already. Is there a difference between being a human and being a person? And then if humans are organisms as well as persons, why doesn't the biological death apply to them? And also, furthermore, does that mean there are two deaths? Is there a death of the person and then a death of the human organism? And then questions come up such as, what about disabled individuals who may have a lower level of cognition, or the mentally ill that may have a lower level of cognition, or either one which has an impaired ability to think, reason? And what about those with Alzheimer's disease who may have an impaired ability to remember and to function independently? How do all these groups of people, are they dead? If somebody is unable to think, reason, or remember and can't perform their activities of daily living. As demonstrated by the biological psychosocial debate, medical facts alone cannot yield a definition of death. Defining death has philosophical, religious, and legal components that cannot be overlooked. Consider again the example of the patient in a persistent vegetative state. Medical facts would deem this patient dead from a psychosocial perspective, but alive from a biological perspective. To add to the complexity, some bioethicists would view death as an event when the biological organism, the human, ceases to function, and that moment is based off the cessation of functioning of either the heart and lungs or the brainstem. Other bioethicists argue that it is impossible to pinpoint a single criterion of human death because death is a process through which capacities are compromised. The question then becomes, is it reasonable to say a human was fully alive at a given point, then the death process began, and is fully dead by the end of the process, but the human is neither fully alive nor fully dead during the process? This raises the question of mortality during the process of dying. If we reflect back to the Harvard Committee report from which the whole brain definition of death was developed, this definition was offered as a criteria for determining death grounded in the conceptualization of organic integration defining life. Some commentators have argued that the intent behind this criteria was not to redefine death, but rather to offer a set of conditions for allowing death to occur. In other words, is the whole brain definition of death a set of criteria that when met permits the artificial maintenance of life? Was the committee offering up ground rules for how to treat a person while in the dying process, and when it is acceptable to withdraw life support? If death is a philosophical, religious, and legal issue, what role should individual autonomy and personal values and beliefs play when defining death? Some commentators have suggested that allowing an individual to choose which definition they want applied to themselves would maximize personal freedom and support the ideals of a democratic and pluralistic society. However, other commentators worry that a choose-your-own-adventure method will create confusion and controversy. They worry that the general public would fail to grasp or embrace the validity of multiple definitions of death. Ultimately, when it comes to defining death, there is a general agreement that death involves the permanent and irreversible cessation of relevant aspects of life. However, what those relevant aspects of life are is highly controversial. Thus, establishing criteria for death remains inevitably and unavoidably problematic. The complexities only grow when we begin to consider specific cases such as voluntary death, death with foreknowledge, and how to define suicide. Traditionally speaking, death as a result of placing oneself in circumstances that one knew to be life-ending was considered an act of suicide. However, some modern philosophers have applied cases of voluntary deaths to challenge this tradition and broad interpretation. In this part of the lecture, we will focus on the taking of one's own life. In the next section of the lecture, we will transition to a similar but distinct discussion of euthanasia. The traditional broad definition of suicide has begged the question of being too broad. Specifically, critics questioned if every act of voluntary death with foreknowledge was an intentional ending of one's life. In other words, critics suggested that it can be possible to have foreknowledge that an act will end one's life without the act being freely chosen and thus intentional. The first example is a self-sacrificial death where the intent of ending one's life is part of a larger effort to save the lives of others. The second example are coerced deaths, such as the case of Socrates, where he was either going to kill himself or be killed by others. Examples such as these have produced more questions than answers. Questions such as, can suicide ever be right? Can suicide ever be moral? Is there an honorable form of suicide? Can suicide be a rational and justifiable act? Or is suicide always the result of a physical or psychological compulsion and thus never rational? These are not just questions of the modern era, but rather questions that ethicists have grappled with since the time of Plato and Aristotle. The dialogue surrounding suicide dates as far back as ancient Greece. Facing his own death sentence in 399 BC, Socrates wrote to Plato, quote, "So, it is not unreasonable to say that we must not put an end to ourselves until God sends some necessary circumstances like the one which we are facing now." End quote. Plato himself considered voluntary death a disgrace and an offense against the divine, but tolerated exceptions such as extreme misfortune, hardship, personal disgrace, and self-administered capital punishment. Like Plato, many ancient cultures permitted and respected rational suicide, the ending of one's own life for good reasons, as opposed to psychological or emotional reasons. In ancient Greece and Rome, suicide was considered a rational choice when life no longer seemed accord with nature. As discussed by the Roman philosopher Seneca in the early years CE, wise men live as long as they should, not as long as they can. And life should be measured in terms of quality, not quantity. Dying young or dying old is not of concern. What matters is dying well. Aristotle was in opposition to this general stance, arguing in contrast that taking one's own life went against the instinct of self-preservation and therefore should always be condemned as an unnatural act. The early Christians viewed suicide as a means to get to heaven. This view threatened the stability of the church to such a degree that Augustine urged his fellow bishops to condemn suicide as a violation of the Sixth Commandment. It was not until 100 years later in 562 that, at the Council of Braga, suicide was pronounced a crime against God, who is the sole determinator of life and death. Moving forward to the 13th century, Aquinas further condemned suicide as a sin against self, society, and God, arguing that suicide is contrary to the natural inclination to love the self and keep the self alive, because every part of the self belongs to the community, and because life is God's to give, and therefore only God's to take away. In 1777, David Hume, a Scottish Enlightenment thinker, made what many consider to be the first substantive attempt to defend the permissibility of suicide in his work on suicide. Hume argued that if the individual or society benefited more from taking one's life than not, then the action was permissible and perhaps even praiseworthy. Underlying Hume's argument was the stance that if God created the universe, his will was present in all aspects of the universe, even acts of self-killing. thus making suicide a rational and reasonable act that occurred in the context of a divinely ordered universe. However, not all Enlightenment thinkers agreed with Hume's stance. Kant, for example, was in effusive opposition to this stance. In response to Hume's, Kant offered a four-pronged argument for why suicide was always wrong. 1. Suicide involves a contradiction of free will. Kant believed that we could treat our bodies as we pleased so long as our motive was self-preservation. Suicide always was, in contrast, as a form of self-destruction. 2. Suicide degrades human nature. While life is not a necessity, to live honorably while life lasts is a necessity, and misery or lack of pleasure is not justifiable as a reason to end life. Ending one's own life violates the categorical imperative, as suicide treats one's own self as a means to the end of relief of suffering. 3. Suicide is inconsistent with autonomy. According to Kant, allowing a person to use autonomy to end their own life would destroy the very life, and thus the ability to be autonomous, making suicide again self-contradictory. 4. Suicide violated the law of God. For Kant, suicide was not wrong because God forbade it, but because it destroyed human nature, and thus was an abandonment that reduced one's worth to a sub-animal level. Moving forward once again in history, the 1800s and early 1900s were heavily influenced by utilitarianism and social Darwinism, both promoting suicide using the argument that the weakest and the unfit should be allowed to die for the greater furtherment of society. In 1986, Carolyn Siegel, a medical sociologist, argued that suicide could be rational if the person contemplating suicide had a realistic assessment of their life circumstances, was free from severe emotional distress, and had a motivation that would seem understandable to most uninvolved people in the person's community. Siegel's sentiments were embraced by many in the early 21st century who were supportive of suicide as an acceptable alternative to life when faced with unbearable pain, suffering, or loneliness. Yet, others aligned with Kant and argued that the terms rational and suicide seemed to be in stark contradiction to one another. David Peretz, a psychiatrist and suicidologist, warned that accepting suicide as rational is unethical, dangerous, and harmful. According to Peretz, people have become so overwhelmed with stress related to the fear of death and dying that they have begun to search for new ways to cope. Such searches have sparked an interest in better ways to die, such as dying a good death, dying with dignity, and ultimately, the option to exercise a right to die. Peretz has warned that rational suicide leads to a false sense of omnipotence and misconstrues self-destruction as a form of autonomy and freedom from suffering, loneliness, or frailty. Nurse ethicists Rick and Butts have acknowledged that each situation is individual, and thus there is no universal ethical response when it comes to suicide. Rather, these researchers suggest that every case should be handled uniquely, and healthcare providers must be well informed of available legal end-of-life interventions, as well as reflect on how their own cultural, religious, and personal beliefs influence their personal as well as professional ethical framework regarding suicide. The ethics surrounding suicide have clearly occupied both philosophers and theologians for centuries. Central to arguments on both sides of the debate are the broad principles surrounding duties to self and society, and the fundamental beliefs about the value of human life, about nature, about purpose, and about the origins of life. As depicted in this brief moral timeline, suicide went from being tolerated to admired, to deemed morally objectionable, and now to being decriminalized. However, euthanasia and assisted death, which are generally viewed as criminal activity, provide an equally intense debate about how much control we can exercise over when and how we die. While suicide involves the taking of one's own life, euthanasia, allowing to die, and assisted death all involve the role of a party beyond just the patient in bringing about death. Compassion is often the motivation cited as underlying euthanasia, allowing to die, and assisted death alike. In all cases, death is foreknown. In euthanasia and assisted death, death is also directly intended. In allowing to die while death is foreknown, the intention of acts, or the omission of acts, is the relief of suffering and pain. For some commentators, this distinction holds significant moral relevance. For others, it is purely semantics and false distinctions. However, the distinction, or lack thereof, holds moral significance when ethically analyzing euthanasia versus allowing to die versus assisted death. Euthanasia comes from the Greek word eu, meaning good, and thanatos, meaning death. Thus, the term directly translates to a good death. Euthanasia is the process through which someone other than the patient, usually a physician, administers a lethal means for the intent of assisting the patient to die. Motivation behind euthanasia is generally considered to be a desire for compassionate relief of pain and suffering of a terminally ill patient. A question of morality that often arises then is there a moral difference between euthanasia and allowing to die? It is important to note that physician-assisted suicide, or PAS, is similar to, but not synonymous with euthanasia. In contrast to euthanasia, where someone other than the patient administers the lethal means, in physician-assisted suicide, the patient is provided with the lethal means to self-administer. We will discuss physician-assisted suicide later on in this lecture. Euthanasia can be broken down into narrow and broad interpretations. Some philosophers define euthanasia narrowly as intentionally killing, which can take the form of an act termed active euthanasia or a failure to act, passive euthanasia. In active euthanasia, someone, usually the physician, intentionally causes a patient's death by performing an action such as administering a lethal injection. In passive euthanasia, someone, again usually the physician, causes the patient's death by not taking the usual and customary actions such as not providing antibiotics to a terminally ill patient. Central to both active and passive euthanasia is intention. Under the narrow definition of euthanasia, unless the death was intentionally caused by what was or was not done, an act or omission of action is not euthanasia. It is termed allowing to die. If the intent is not to hasten death, but rather some other purpose such as avoiding pain from futile interventions, then death is deemed unintended but likely a consequence. Allowing to die is a sound medical practice supported by law and professional ethics and is the premise of hospice services. In contrast, the broad interpretation of euthanasia views both killing and allowing to die as euthanasia. Thus, philosophers who hold to this broad interpretation must view all forms of euthanasia in the same light as how they view allowing to die. In other words, if allowing to die is wrong, then all forms of euthanasia are wrong. If allowing to die is not always wrong, then neither are other forms of euthanasia. The question then becomes, should there be a moral distinction between killing via acts or omissions of acts and allowing one to die? For those who hold to the broad interpretation of euthanasia, the answer is no. However, supporters of the narrow definition would disagree. Those who hold to the narrow definition of euthanasia distinguish between harms that are actively caused and harms that are permitted. In euthanasia, the person acting or omitting the action causes the death. In allowing to die, the disease causes the death. These commentators warn that if the distinction between euthanasia and allowing to die is removed and allowing to die is deemed a form of euthanasia, a slippery slope will be created that could lead to making active euthanasia acceptable and permissible. Commentators who support the broad view of euthanasia disagree with this stance and argue that what is important is not the intent behind the act or lack of act, but the outcome, which is always death. These commentators argue that merely foreseeing the death as certain or nearly certain is enough to characterize an act or omission as an intentional termination of life and therefore euthanasia. This argument went all the way to the Supreme Court in 1997. The results of the 1997 U.S. Supreme Court case Vacco v. Quill concluded that there is a legal distinction between killing and allowing to die. Furthermore, there exists a general professional and social consensus that killing and allowing to die are morally different, and the consensus argues that even if death is imminent, the ordinary care owed to a sick person cannot be legitimately interrupted. In contrast, the cessation of extraordinary means to prolong life, where there is irrefutable evidence that death is imminent, should be left up to the patient and the patient's family. The conclusion was that the emphasis should be on intent, not foreknowledge. Even if death is foreseen and foreknown, if the intent of the action or omission is not to hasten death, then the act or omission is not immoral. Consider, for example, terminal sedation, the practice of administering increasing doses of analgesic and sedative drugs when the symptoms of a dying patient cannot be eliminated by other appropriate and acceptable means. These drugs do suppress consciousness and can hasten death. However, as long as the intent behind giving the medication is to ease pain and suffering, terminal sedation is considered not only legal, but a valuable therapeutic adjunct with end-of-life care. Another important conceptual issue in euthanasia discourse involves patient wishes. Patient decisions about life and death ordinarily are characterized as voluntary or non-voluntary. Voluntary decisions about death refer to cases of competent adult patients requesting or giving informed consent to a particular course of medical treatment or non-treatment. Advance directives and living wills are examples of voluntary decisions about death. Regardless of what the patient's wishes are, one thing is certain. For the decision to be voluntary, the patient's consent must be explicit. When the patient who is going to die has not provided explicit instructions on their preferred course of treatment or non-treatment, death decisions are considered non-voluntary. In these cases, the course of action is based on two questions. From a medical perspective, what is best for the patient? From a legal and moral perspective, what would the patient want if they could choose? If the answer to the two questions are in contrast, generally speaking, the second question takes priority over the first. However, this does not often settle the issue. Patient wishes are often unclear or ambiguous. Besides voluntary and non-voluntary decisions, a third decision has also been theoretically proposed. An involuntary decision would be a decision made in contrast to the patient's expressed wishes. Reflecting on the suicide discussion, we now must ethically consider, do patients have a right to die? And is overriding a patient's wishes to live a form of murder and killing? Assisted death is usually considered a form of euthanasia in which an individual expressing a wish to die prematurely is helped to accomplish this goal by another person. Under the law, assisted death may be regarded as homicide or suicide, and the person providing assistance may be held legally responsible for the death. The most commonly acknowledged form of assisted death is physician-assisted suicide, or PAS, where the physician provides the patient with the lethal means but does not actually administer the means to the patient. Currently, physician-assisted suicide is legal in 11 states. However, legal versus illegal does not always equate with moral versus immoral. Thus, for moral guidance on physician-assisted suicide and assisted death, many people turn to either principles or virtues. Underlying all principle-based assumptions is that there is an answer to the broad ethical question of what ought I do? In other words, the question, ought I ever practice assisted death or have it practiced on me, can be definitively answered based on principle. This question is generally answered using one of three prominent moral principles: utility, respect, or divine command. Yet, as has already been shown time and again, different principles lead to different conclusions regarding what ought I do, and sometimes the same principle can be used to both condemn and condone an act. Simply put, moral principles are morally ambiguous regarding the propriety of certain ethical dilemmas, such as assisted death. The variance in ambiguity is not unique to the ethical dilemma of physician-assisted suicide. However, this ethical dilemma provides a golden opportunity to draw attention to the phenomenon and deepen our understanding of the controversy that can arise when commentators are in accord with one another on moral rule, but are at odds regarding its application. Following utilitarianism, or the utility principle, means doing what likely will yield the greatest net happiness of all alternatives. Thus, the question naturally arises as to whose net happiness should be considered, the individual's self-interest or social interest. With regard to individual self-interest, according to Bentham and Mill, a proper application of utilitarianism permits suicide and euthanasia as a demonstrably private affair. Individuals should live their lives as they see fit, based on their own values and beliefs, so long as they're not harming others. Patients who face a future whereby they will be able to satisfy very few preferences should therefore be permitted to a coherent and informed preference for assisted death. Additionally, some theorists have argued that having physician-assisted suicide available may in fact help patients choose life. Some patients simply want a feeling of having a choice of ending their life available to them should their condition progress to a horrible situation. In contrast, some theorists argue that access to a quick and painless death is not always in the best interest of the patients. Common support for this argument includes cases of mistaken diagnoses and prognoses. These commentators argue that while knowing assisted death is available may bring forth comfort for the patient, there is also the risk that this same knowledge may make one inclined to give up too easily. With regard to social interest, many theorists argue that unlike suicide, physician-assisted death is not a wholly private act. At least one person is facilitating the death of another. Thus, physician-assisted suicide not only is a question of personal morality, but a question of social morality. Social morality involves recognizing that social policy cannot create a perfect system. Instead, the ethical response to assisted death is the response where the overall benefit to society from the act of assisted death will outweigh the costs to society. For many moralists, it isn't utility or happiness that should govern morality, but rather respect for persons. As stated by Kant, people should always treat others as an end in themselves, never merely as a means to ends. Thus, morality based on the principle of respect is all about honoring autonomy, reciprocity, and dignity. Applying these three ideals to assisted suicide, however, turns up the same moral ambiguity as implementing utility does. For advocates of assisted death, autonomy, meaning choosing for oneself, acting in one's own reason based upon one's own goals and aspirations. Thus, the ability to control when and how one dies is a final act of autonomy. In contrast, opponents of assisted death argue that while autonomy is the freedom to make choices for oneself, freedom is being used against the self in this case of taking one's own life, and is the irreversible relinquishing of autonomy, not a final autonomous act. Many of these commentators further question if ending one's own life can ever be the result of a competent person making a rational and autonomous decision. The second component of respect is reciprocity, treating others as we would want to be treated. Thus, supporters of assisted suicide argue that if involuntary euthanasia is objectionable because it goes against a person's will, then refusing to allow assisted suicide should also be objectionable for going against a person's will. Opposers of assisted suicide provide a counter-argument that a want to die does not equate to a right to die. Equating a desire to die with a right to die is a form of cheapening life. They support their stance with the argument that a desire to kill another does not yield a right to kill another. The final component of respect is dignity, allowing one to live as they see fit. For many supporters of assisted death, their argument is heavily grounded in the concept of death with dignity. Supporters argue that assisted death provides the patient control to choose to die before extreme suffering and wasting away in a hospital bed may occur. To supporters of assisted death, not allowing assistance with death is a form of indignity. In contrast, opposers of assisted death argue that death with dignity should refer to a natural death, devoid of artificial machines or life support. In contrast to this, assisted suicide is avoiding a natural death through killing, which itself is an indignity. Any discussion on the morality of death would be incomplete without a consideration of the role that religion and a belief in a divine creator play in determining the morality of assisted suicide. Just as the Church respects reason expressed in secular ethical theories such as utilitarianism and Kantian ethics, many religious ethicists argue that secular moralists are duty-bound to confront religious viewpoints expressed in divine command. When addressing the morality of assisted death under divine command, one must first consider how humans come to a knowledge of God's will before being able to determine what God's will is. Under special revelation, humans come to know God's will only through reading the Scripture. However, the sacred Scriptures must then be interpreted by man. Therefore, for many Christians, the Bible provides perspectives on suffering and death that are incompatible with suicide and assisted death. However, supporters of assisted suicide argue that Scripture can be used to support assisted suicide in cases of intense suffering, in circumstances where conscious life is no longer possible, and in other situations of pointless existence. Under general revelation, God reveals himself and his truths to humans through nature. Thus, opponents of assisted death argue that a basic moral precept of natural human inclination is to preserve life. Therefore, assisted death goes against human nature and is thus immoral. However, supporters of assisted death provide a counter-argument grounded in free will and rationality. Free will and rationality are what makes us human and what God uses to separate humans from animals. Therefore, an otherwise rational human who desires to die by assisted death should be allowed to exercise their free will in such matters. As demonstrated on the previous slides, principles provide morally ambiguous direction regarding answering the question of ought I ever practice assisted death or have it practiced on me. The other approach to answering this question is application of virtue or character ethics. As opposed to principle-based ethics, which appeal to a principle such as utility, respect, or divine command, virtue ethics appeals to what it means to be a good person. According to Aristotle, above all else, a virtuous person possesses phronesis, or practical wisdom that allows us to act in means between extremes of excess and deficiency. Thus, the morally permissible decision is always the decision that a person of phronesis, or practical wisdom, would perform under the given circumstances. An act is not permissible because a person with phronesis would perform it, but rather because the act possesses other characteristics of virtue such as courage or compassion. Thus, the question regarding the morality of assisted death is not, ought I ever practice assisted death or have it practiced on me, but rather the question should be, would a virtuous person, a person of practical wisdom, ever assist death? According to Aristotle, no, a virtuous person would never assist with death because the point of life is to attain eudaimonia, to fulfill oneself through the development of character, and suicide makes this process impossible. However, while virtue ethics is profoundly concerned with the effect of what we do on what we become, virtue ethics is also about how what we do reflects who we are. Thus, supporters of assisted death argue that failure to assist a consenting patient in death causes the healthcare professional to fall short of professional ethics by failing to respect the patient's autonomy, by allowing the extension of pain and suffering, by not providing the benefit of ceasing pain and suffering, and by not repaying the harm done from any prior attempts to prolong life. In other words, supporters of assisted death view healthcare professionals who decline to assist a patient as a form of abandonment. In contrast, those in opposition to assisted death call on the Hippocratic Oath and the position of the American Medical Association that good care providers sustain medicine as a social practice, in part by avoiding assistance in death. Opposers further their argument stating that assisting in death is a form of misplaced compassion for the dying, either conscious or unconscious. Instead of assisting in death, the moral care provider should consider how to address the inadequacy of pain control and care for terminally ill patients, which often underlies requests for assisted death. Both principle-based ethics and virtue-based ethics are ambiguous with regard to the morality of assisted death at the individual level. However, assisted death isn't only a question of personal morality, but also a question of social morality. This underlying struggle at the individual level provides the foundation for the struggle to reach a cultural consensus and form social policies about assisted death, such as, should assisted death be legal? The question of the legality of assisted death is part of a much larger ethical question. What is the ideal society? Historically, the ideal society has been consistently defined as a just society. However, significant disagreement exists over what makes a just society. The three top contenders for what principles should underlie a just society include individual rights, equal treatment, and general welfare. Application of these three principles have effectively split society into two camps: retentionists, who want to retain prohibition on assisted death, and abolitionists, who want to abolish prohibition in favor of permissive legislation supporting assisted death. Underlying individual rights is the understanding that if somebody has a right to something, then somebody else has a duty to either not interfere with that right or possibly help the person achieve the right. Thus, abolitionists assert that a right to die means two things. First, competent terminally ill adults are entitled to be left alone in choosing to hasten their death. Second, a right to die implies that someone else must assist in the death. In contrast, retentionists assert that assisted death should remain prohibited based on defending the sanctity of life and because each life warrants equal concern. Retentionists voice their concern that legalizing assisted death is a slippery slope that has the potential to jeopardize the well-being of the weak and the vulnerable. To further support their stances, both abolitionists and retentionists dig deeper into the concept of individual rights by specifically addressing and highlighting human rights and welfare rights. Human rights, in contrast to legal rights, which are rights supported by the law, are rights derived merely from being a human. Abolitionists argue that determining the manner of one's own death is a human right that should be supported and defended by law. In response, retentionists voice concern that legalizing the right to die opens the door for people to act from an array of complex motives to justify assisting death. For example, if the right to die was legalized for terminally ill patients, what stops this from being extended to those with incurable diseases or severely life-limiting disabilities? Regardless of if assisted death should be considered an individual human right, abolitionists argue that assisted death is a welfare right, a right owed to them as a special category of human, competent and terminally ill. Abolitionists argue that there is no more basic expression of morality and self-determination than how one is going to die. Thus, assisted death is a part of a democratic society's commitment to the dignity and autonomy of its members. Retentionists respond that assisted suicide does not just involve individuals, but also a healthcare provider, and therefore becomes a social decision between two people, one who wants to be killed and one who is willing to do the killing. Thus, assisted death is not a welfare right owed to individuals, but rather a decision that impacts more than just self-determination. The second area of consideration is equality. But what exactly does equal treatment require of a just society? Equal treatment can be considered a procedural matter, meaning that equal treatment is treatment according to the same laws and legal procedures for all. Or equal treatment can be considered a matter of fairness, where all receive equal freedom under the law. Viewing equal treatment from the procedural view is often supported by retentionists who argue that laws prohibiting assisted death and governing end-of-life care in general are fine as they are written, and nothing should be changed as long as everyone gets the full benefits from what is permitted under the law, and everyone disallows what is not permitted under the law. The abolitionists respond by arguing that justice is not procedural equity, but rather justice should be fairness, pointing out that not all laws are fair and just, and that some laws actually mask and perpetuate deep social injustices. Abolitionists argue that in the case of very ill patients desiring assisted death, they simply can't enjoy the same measure of freedom as those who don't desire assisted death. Thus, the only way to provide equal freedom and equal treatment under the law would be to abolish the prohibition of assisted death. In response, retentionists voice concerns that instead of providing equal freedom for all, legalizing assisted death has the potential to provide unequal treatment to vulnerable groups and the severely disabled. Along with individual rights and equality, the just society is thought to be one that promotes the general welfare or common good. However, like most of the other considerations we have discussed thus far, what constitutes the common good and how the government can rightly promote it is not easy to ascertain. State paternalism refers to actions of government bodies or agencies over particular kinds of activities or procedures. In certain cases, the paternalistic intervention is obvious. The potential harm to people is clear and present. Other times, however, harm is less clear, and so limitations on the liberty of individuals by the intervention becomes controversial. Underlying the common good argument surrounding assisted death is this concept of harm, and whether or not legalizing assisted death would bring harm to society. When determining the proper reach of state involvement, many turn to the utilitarian distinction between self-regarding and other-regarding vices. A self-regarding vice is one that might directly harm an individual who engages in the activity or decision, but would not harm anyone else. Other-regarding vices are those activities that threaten direct harm to others. Regarding the assisted death debate, abolitionists argue that if an individual wants to die a quick, painless death rather than a lingering, painful one, it's no one's business but his own. Thus, assisted death is a self-regarding, harmless event. It is not a vice, and it is not harming anybody. Many retentionists respond indicating that assisted death is not a harmless act, and it is questionable if the act is indeed self-regarding. Retentionists point out concerns such as the harmful effects on the physician-patient relationship, the diversion of resources from comfort care, and the adverse impacts on families, health care, and medical services, including hospice. Much of the retentionist opposition to legalizing assisted death is the slippery slope that if assisted death were legalized, euthanasia would inevitably follow, and euthanasia would be extended to the disabled, the clinically depressed, the chronically debilitated, racial minorities, women, the elderly, and deformed newborns. Retentionists warn that there is a true risk for a rising of a second Auschwitz type situation in which someone else is now legally allowed to enforce another individual's right to die despite personal preferences. In response, abolitionists argue that safeguards can be put in place to prevent such acts from happening, and that the sacredness of the physician-patient relationship should serve as the foundation for creating these safe laws. Abolitionists argue that while retentionists speak of fears of potential indirect harms, society is continuing to provide direct harm to patients requesting assisted death through abandoning these patients to their suffering. Questions of duty, intent, outcome, and virtue elude the ability to make a societal-level decision on the morality of euthanasia and assisted suicide. However, society has actually reached some level of social agreement regarding the care and treatment of the terminally ill. Inquiry regarding advance directives or living wills upon admission to hospitals is now mandated to help ensure patient wishes will be met. The intent is to provide a quality end-of-life experiences that minimizes suffering and respects the patients. Patients have a right to die through the services of hospice or palliative care. Similarly, patients have a right to refuse life-sustaining treatment such as IVs, food, and water. Patients have a right to the most powerful analgesics, even if they shorten life. And patients have a right to life through the efforts of advanced care life support and resuscitative measures. However, as we will discuss on the upcoming slides, ethical debate still exists regarding to what extent should patients have a right to life. The older population in the United States is defined as those over the age of 65. This population is growing faster than the general population in the U.S. The United States Census Bureau estimated that in 2023, 17.7% of the U.S. population was 65 years or older. Current projections hold that by 2040, the population in the U.S. aged 65 or older will reach 22%. According to the Institute for Health Metrics and Evaluation at the University of Washington School of Medicine, 40% of total healthcare expenditure in 2023 was dedicated to the population over 65, with 63% of medical expenses for this population being covered by Medicare. The percent of healthcare expenditures spent during the last year of life for the U.S. population has remained steady at about 10 to 12% since the early 2000s. Yet, the continued projection of the growth of the older population, coupled with advances in extensive life-extending technologies, have perpetuated questions and concerns regarding society's ability to meet future healthcare needs. Most commentators agree that responsible healthcare reform must provide healthcare coverage for all Americans while at the same time reducing the rate of growth in healthcare spending. Furthermore, many concur that these goals must be achieved in a fiscally responsible manner with sustainable sources of funding. However, according to most experts, this goal is only possible with some kind of healthcare prioritization. Many healthcare resources are already limited. The significant percentage of healthcare expenditure being spent on older adults, as well as those at the end of life, draws attention to the final controversial ethical issue we will discuss surrounding end-of-life issues. The ethical issues regarding the rationing of healthcare for the older adults and rationing of healthcare at the end of life. Rationing refers to the controlled distribution of resources, particularly scarce goods or services. In instances where the resources happen to be healthcare related, such as organs, medicine, procedures, treatments, and therapies, healthcare is what is being rationed. Healthcare rationing is most simply defined as the planning for equitable allocation, appointment, or distribution of available health resources. The motivation underlying healthcare rationing is financial. However, the intended outcome of healthcare rationing is fairness. Thus, healthcare rationing is inevitably a conflict between medicine and money that is typically experienced as a conflict between what a physician or care provider considers to be the best treatment for a patient medically and ethically against the treatment the patient's insurance covers. While many agree that some form of rationing of healthcare is necessary in society, the current outcomes of rationing, such as the delay or denial of medically warranted treatment, is unacceptable. Determining the grounds on which to ration healthcare has presented as an ethical challenge for society for decades. Currently, the two most common suggested criterion for rationing healthcare are age-based rationing and rationing based on medical futility. The concept of age-based healthcare rationing dates back to the early 1980s when economist Alan Greenspan wondered whether it was, quote, worth it to spend nearly one-third of Medicare on the 5 to 6% of all Medicaid insurees who were going to die within a year. Similarly, in 1984, Richard Long, the governor of Colorado at the time, was quoted to have said that older people have a duty to die and get out of the way of younger generations. This was followed in 1987 by bioethicist Daniel Callahan, who wrote a controversial book titled Setting Limits, in which he criticized the nation's healthcare system for devoting a disproportionate amount of healthcare resources to the elderly. Callahan's age-based rationing argument was largely utilitarian in nature and grounded in the concept of the greatest good for the greatest number. Callahan argued that the elderly generally required an extensive amount of treatment and complex interventions that often were ineffective and yielded little benefit to society. Thus, he deemed the elderly population a new social threat and argued that it was their responsibility to step aside and sacrifice for the young. As a result of Callahan's work, age-based rationing grew into a public issue of both cost-effectiveness and distributive justice that was furthered by the 1995 U.S. Census Bureau's assessment that the U.S. would become a nation of the elderly by the year 2050. While Callahan emphasized that the elderly receiving a disproportionately high share of overall healthcare resources with little benefit to society as a result was unjust, others argued that because the elderly had enjoyed the opportunity to live a long time, it was only fair for the old to give the young a similar opportunity. This line of thinking became known as the fair innings argument and has become the foundation underlying most arguments in support of age-based rationing. According to the fair innings argument, every person is entitled to a normal lifespan which should be determined as a set number of years. The fair innings argument requires that every person be given enough health resources to reach the appropriate threshold of a normal lifespan. Once somebody has reached this threshold, they are no longer entitled to health care resources, and thus resources should be spent on ensuring that others can reach this same ideal maximum threshold. Not surprisingly, age-based rationing was met with considerable opposition. While Callahan used cost-effectiveness to support age-based rationing, opposers respond by arguing that it has not necessarily been the aging population that has driven up healthcare costs, but rather medical technologies and their intensive application. Opposers further argue that there is no guarantee that any potential savings from age-based rationing would rebound and be spent on the young, or that these savings would make any significant difference in the overall healthcare expenditure. From a stance of distributive justice, opposers of age-based rationing argue that equal treatment requires individuals to be treated equally in the absence of morally relevant reasons for treating them differently. Thus, opposers state age is not a morally relevant reason to discriminate and should be no more relevant in allocating health care resources than race, sex, or religion are. Furthermore, opposers voice concerns that age-based rationing is a slippery slope. If withholding care from the elderly because they do not provide benefit to society can be justified as ethical, this opens the door to restricting other unproductive groups such as the disabled, the destitute, and the incarcerated from receiving access to health care. Supporters and opposers of age-based rationing may disagree over the fundamental concepts underlying cost-effectiveness, social outcomes, and distributive justice. However, both groups acknowledge that substantial investment that Medicare makes in end-of-life care. Costs at the end of life are extremely high, and the United States healthcare system is set up to try to preserve life at all expenses, both figuratively and literally. However, many would argue, and science would support, that some care is actually futile and neither extends nor improves the quality of life. Thus, instead of rationing care based on age, some have argued that instead we should ration health care based on medical futility. Healthcare resources are limited and thus need to be rationed based on some standard of equitable and just means. Could medical futility provide an agreeable and objective ground on which to ration healthcare? Healthcare rationing involves societal decision-making about the allocation of beneficial treatments among patients. Medical care is deemed futile when it neither extends nor improves the quality of life. Futility is thus a medical decision about whether a treatment will benefit a patient. Therefore, healthcare rationing and medical futility intersect when the benefits of treatment are brought into question alongside the consideration of resource allocation. Medical futility inevitably pits care provider professionalism against modern patient self-determination, because care providers and patients, or their surrogates, do not always agree about what futile means and whether or not a treatment or procedure is rightly deemed futile. When cases surrounding continuation of futile care are brought before the courts, legal proceedings consistently weigh in on the side of supporting individual autonomy of the patient. It has been thoroughly discussed and clearly articulated that individual patient autonomy includes a right to die through the means of hospice and palliative care via the refusal or cessation of life-sustaining treatment. Thus, we must ask, does individual autonomy include a complementary right to live that supersedes a care provider's judgment to terminate treatment because of futility? In other words, can patient autonomy override care provider beneficence and compel treatment at the end of life, even when the provider believes treatment is medically worthless? The morality of medical futility lies in the answer to this question. If the answer is yes, then patients are entitled to a certain level of health care regardless of their condition, and the healthcare providers are obligated to provide this care. Thus, the case of rationing based on futility loses much of its moral force. However, on the other hand, if the answer is no, then patients have no such claim and care providers have no such obligation, thereby strengthening the case for rationing by futility. In general, the case for making a judgment in support of rationing based on medical futility is grounded in either professionalism and the traditional values and standards of medicine, or social justice and responsible stewardship. Modern Western medicine is grounded in the traditional norm of beneficence, which directs care providers to apply their insights and techniques only for patient good and to provide treatments that they believe will be beneficial or at least not harmful to patients. For example, the American Medical Association's Professional Code of Ethics tells physicians not to provide or seek compensation for services that are known to be unreasonable or worthless. Arguments grounded in professionalism assert that care providers have a right to exercise their own autonomy to practice healthcare responsibly. Thus, when patient and family choices or demands are unreasonable, care providers are duty-bound to educate patients and families to make a rational choice. To do otherwise, to accede to treatment with no medical indication or scientific validity would violate beneficence. Therefore, from a stance of professionalism, patients' rights to choose are limited and properly understood only by reference to the provider's right and duty to practice responsibly. In other words, patients should not be given treatment simply because they demand or request them. To do so would be a misrepresentation of professional knowledge and skill, or in other words, a form of professional fraud. From the stance of responsible stewardship, providing treatment that fails to achieve the desired physiological effects wastes scarce resources such as time, equipment, transplantable organs, and even money. The link between cost and futility has been recognized since at least the early 1990s when Dr. George Lundenberg, the editor of the Journal of the American Medical Association, proclaimed that futile care policies are one criterion of healthcare cost control. Lumberg argued that healthcare is a limited resource and access unreasonable medical care is unfair and unacceptable. Those in favor of rationing based on medical futility argue that patients and surrogates cannot be given the absolute right to demand any treatment they choose. If they were, those treatments would be given at the expense of the poor, the powerless, and the marginalized. Thus, care providers have a special responsibility to avoid this injustice by practicing prudent stewardship of scarce medical resources when determining what constitutes reasonable medical treatment. In response, for their part, patients and families should agree to restrict their self-advocacy to what is fair and equitable for all. Combining the considerations of professionalism and responsible stewardship, researchers at Dartmouth found that medical centers who spend the most on end-of-life care seem to have no better results than those that spend much less, thus suggesting that rationing based on medical futility would not change end-of-life outcomes for patients. However, as one would expect, there still exists strong opposition to rationing based on futility. Society is understandably divided on many issues regarding death and the end of life, issues that span from the mere definition of death to defining suicide, to determining if people should be allowed to choose to die, to how care can be rationed, and many issues that were not even breached in this lecture. Yet, public opinion, society, and individual ethical frameworks all acknowledge the moral importance of providing quality end-of-life care. If this were not the case, we would not have had such a long lecture, and we wouldn't have had to choose which end-of-life topics to discuss. While what defines quality end-of-life care may vary among us, the consensus is that all people deserve to die a good death. What defines a good death is a question that each of us must grapple with, and each of us must answer for ourselves, both personally and professionally. And as you go forward from this lecture, which merely scratches the surface of end-of-life ethical issues, I challenge you to consider, how do you define a good death as an individual, and how do you define a good death as a healthcare provider?